Amongst us, we have our next speaker this evening, a very special personality, the gem speaker, Dr. Amitav Banerjee, MD, Post-Doctoral Clinical Epidemiology. Currently, Dr. Amitav is Professor and Head Department of Community Medicine, D.Y. Patil Medical College, Hospital and Research Center, Pune. He had served in Indian Armed Forces for more than 25 years and has been receiver of many prestigious awards for his researches and publications. Few among them are Director General Armed Forces Medical Service Award for his paper in tribal malaria. He has published more than 200 papers in peer-reviewed journals globally. He has been currently the member of Pune Task Force for COVID General. He has been a resource person to very many national and international conferences. Today, he'll be enlightening us on the topic COVID-19 and immunity, an epidemiological perspective. I welcome you, sir, Dr. Amitav Banerjee.
Thank you, madam. Thank you for the kind words. And I thank the organizers for giving me this opportunity. Basically, I'll be talking from the epidemiological perspective. So as an epidemiologist, we just know what is happening on the ground. We are not basic scientists. We can't go into the depth, but we can generate ideas. And it is for the basic scientists to take it forward. So I will be trying to give a global overview and if possible, something about our country also, some data we have got, which gives some clues to how to explore the immunity aspect of the COVID-19. And of course, immunity is a very vast term. So it is I would use it as a resistance to disease because there are a lot of, so I would just give a short presentation and after that we will see how we can proceed after that. So I'll be sharing my thoughts to this. Share the screen. So the immunity and epidemiological perspective. And I'd like to, how to share the screen.
Sendil, view.
View, I'll go to view and then I'll change. I want to make it I want the slideshow. Actually, this is a Apple computer and I'm not very conversant with this.
Play button. It's in the center of your screen.
Reno, just tell me how to share the screen here. This has
It is visible, sir. You have to just enlarge it.
It's covered, no? Enlarge कैसे करें इसको? Slide से. नहीं, share तो हो रहा है, but full screen करना है ना? ये ऊपर का play कहाँ चला गया?
Slide play कर रहा है.
हाँ, full screen जो करते हैं ना? Slide show करना है ना? Play. हाँ. Yeah, I think now we can see. Sorry for the interruption.
No problem.
Anyway, so basically, epidemiological approach is a very simple approach. We just ask questions and see the patterns. So what is the event and who are getting affected? So once you compare who are getting affected, who are not getting affected, you get some clues to the immunity aspect, where they are affected, when and why. And then what can be done to improve the health in the context of this pandemic, how to prevent the impact in the future, any other pandemic of communicable disease, and what are the difficulties which we have in these actions. So anyway, this is just rapidly recouping how the pandemic started. Up to a couple of weeks back, this was the proposed this from the bat, from the animal kingdom, it jumped into the humans. But now there are other possibilities, whether it is due to lab leak from the virus, maybe an accident or by trying to do some research in gain in function. So this is epidemiologically, this is also important because the agent factor, that is the virus. So whether it is a natural agent or whether it is some sort of doctoring has been done or some genetic engineering has been done. So these are issues for the basic scientists. So we leave it at that. But however, whatever way it originated, it is behaving like a virus with its mutations, with its adaptations, which are the natural biological phenomena. So we just, and we know how it proceeded. It outbreak originated in Wuhan. So now it is equal possibility, whether it is wet market or whether it is the lab. So whatever it is, the China put the district, Hubei district, under lockdown in January. This Wuhan was in Hubei district. And when the China did it, the whole world criticized China. And legal experts said this is unconstitutional. The WHO experts said this is unscientific. So this pandemic has brought out the hypocrisy of world governments also, because just a few months later, many countries outdid, or most of the countries outdid in these restrictive measures. So anyway, it spread to other countries, and the very countries which had criticized China, they surpassed it in implementing these measures, and different jargons have come into it that flatten the curve, and as if you can check the transmission. So it has shown, experience has shown that you can just postpone the transmission. You cannot really flatten it. If you flatten it, it prolongs, and we have the second wave as a result of that. So those are different issues. So whatever initial, why the overreaction? Because the lethality of virus was overestimated. And even in the study published in Lancet, the case fatality rate was estimated to be 20%. And this distortion occurred because in Italy, the large number of casualties were there. And these casualties, most of the people who succumbed to it were, average age was 80 years. So those things were overlooked. And this, and most of were admitted and 80 years with comorbidities. So this was projected to make those mathematical models of great devastations and death, which created global panic. And so this is also a part of immunity. Elderly people have got a low immunity. So when epidemiology you have to see the demography also. The population immunity depends on the age profile. Overall, when you make the mathematical models, you have to say the younger population, countries with younger population will have a higher level of population immunity. As an epidemiologist, I can talk of population immunity. Individual level immunity is a basic science. Thailand was the first country outside China to be affected by COVID-19, but even today, it has got one of the lowest rates. So again, there are other racial factors or genetic factors, or Asian countries, African countries, the immunity appears to be more against this viral. It may be due to the age, and as we will see subsequently, it may be due to the body mass index also. From the data, it appears that immunity to COVID, particularly for fatality, is related to your obesity. And it may be indirectly also because it may be a surrogate marker of comorbidities like diabetes or hypertension or other non-communicable disease. So Italy was the first country to impose the countrywide lockdown. And then there were other failures also. Scientific institutions, as I said, they make models on these inputs which were not applicable to the globe, but the whole globe got panicked. And humans were taken as units, as if they are rather than social beings. And therefore, this academic and scientific anarchy ruled the beginning phase of the pandemic, and a lot of collateral damage and all we know that has occurred. So then, of course, according to the precautionary principles, the social distancing, mask and test, trace, isolate, and lockdowns were here. These are very harsh measures. And you will be surprised to know that most of these were based on computer models, simulation models, or social distancing, about, say, lockdowns. In fact, this model was not even by scientists. This was the model which was developed as a school project by one of the scientists' daughter. So she was working on a school project on influenza and closing of schools and lockdown, and she made a computer project, and later on the basis of this, they went for this drastic measure. So if you just see the literature, you'll be surprised to know that how weak was the foundation of this drastic measures. So anyway, these measures required to be reviewed from time to time because these measures are causing a lot of collateral damage. So that is besides the point at present. But anyway, it has got like poverty. People are losing livelihoods. People, the large number of children in developing countries will be malnourished. So it is well known that malnourishment reduces the immunity. It has a negative impact on immunity. It will make a person susceptible to infectious disease. Perhaps it may make them susceptible to even coronavirus. So in the long term, this will affect immunity. If you have to think of the bigger picture, so this collateral damage may reduce immunity indirectly. So because what is happening now, the whole world is only focusing on the coronavirus and the corona disease. So you see, it is just a label. But if you see trying to chase this, you are causing the negative impact on overall immunity because of loss of livelihoods and malnutrition. So anyway, this lockdown, how effective it is, because majority of the countries went for lockdown. There were only few outliers like Sweden, Belarus in Europe, and in Japan. Japan in Asia did not have lockdown. And we will just see the comparative figures. If you see the comparative figures, you find it the actual death rate from coronavirus was more depending on which continent we are collecting the data from. The European countries had a particular death rate on the higher side. Asian and African countries had lower death rates. Among the Asian African countries, also some countries which have got higher obesity rate, they had higher death. So that gives an epidemiological perspective on the immunity to COVID. So these are another thing from the data so far, and it is well known by now that people with comorbidities are many more times more likely to succumb to the disease, that is uncontrolled hypertension, uncontrolled diabetes, renal disease, obesity. And of course, this group of people have good immunity against COVID disease. Most of them get asymptomatic or mild disease, and death is very unlikely in children, young adults, and healthy elderly with comorbidities. In fact, in the Western countries, up to 70 years, they say if you don't have comorbidity, you have got almost 0.05% chance. Up to 70 years in developed countries. It is after 70 years, most of the deaths are taking place after 70 years. But unfortunately, in countries like India and Asian countries, we get diabetes, we get coronary artery disease a couple of decades earlier than the Western countries due to genetic factors, due to central obesity, due to deprivation in intrauterine life or childhood malnutrition, the syndrome X and poor glucose tolerance. So we have got a little higher susceptibility to non-communicable disease a couple of decades earlier. So, or death rate in the 50s and 40s, maybe slightly more than the Western countries. So here I try to give this example of chess. This is Vishwanath Anand, the world champion, former world champion. So like when you are talking of epidemiology, you can't look only at only one piece, however strong that piece is. So most of the beginners will just play with the queen, and the other pieces neglect. Even small pieces can trap the queen if you are not paying attention to the full board. So not only you have to see at the other pieces, you have to see the different relation of the pieces and the different parts of the board. So that's what I say, the whole, if you take the whole globe, so different, the same virus will behave differently depending on the other pieces on the board or the big picture. So this is how I try to say. And what is happening today, and we may be causing a lot of damage like an amateur chess player, only we are focusing only on that corona. But we have to see in the context of epidemiology, see in the context, person, time, different demographic. So that's why the epidemiological perspective have been lacking throughout the pandemic. Most of the decisions are taken by clinicians who are seeing only one piece, and their perspective is according to the experience they see, but they are not seeing the other diseases and other demographic. So as I said, epidemiology and chess as well. So this is, I would just try to tell you just to show this pattern, which can give some clue. These are, I have just taken a few countries from each continent. 3 continents I have taken, not each. So this is the continent of, say, Europe. in red, and Asia in green, and Africa blue. So if you see, the death rate are in 4 digits in the country of the Western countries, the USA and Europe. I have taken Brazil also, because Brazil also give important lessons. So I have compared the deaths per million. This last column is the deaths per million. And I have compared it with the overweight prevalence, that is BMI above 25. This is from the WHO site. And I have compared it with the median age. So these are the countries with the highest 4-digit death rate are having a high median age in the 40 range, 40 and above median age. Whereas Asia, with exception of Japan is a very interesting, which we will discuss. And of course, Brazil is also very interesting, and a lot of message we get for India also, if you see the Brazil figure. And again, if you see I have taken 2 countries in Africa which has got a high obesity, that is 63% and 54%, Egypt and South Africa. And both of them in Africa, they have got the highest rates of death. But overall, compared to Europe, they are still low because the age is very less, 20, 23, all African countries. Similarly, Asian countries, Thailand is slightly more. But you see, if you see many other countries like Pakistan, Bangladesh, they are profile is very low. Sri Lanka. So these are some of the, Thailand is also very interesting. It has got a high age and a fairly high overweight, but not as high as the Western, and it has got a very low rate. Because it may be many other factors, environmental factors, and other things. Because Thailand, I have been there a couple of times, so there are most of the things are open spaces, well ventilated. The restaurants are also on the streets. Their educational institutions are in the Buddhist monasteries, where it is mostly in the open, well ventilated. Perhaps that may be. I just again, it's a epidemiological perspective, which is just to generate the hypothesis. We don't have. We have to test it to really. And if you see in Europe, Brazil has got a low age, but it has got very high mortality because it has got a very high obesity rate. I mean, it is a very fast developing economy like India, where people become very rich very fast. Their lifestyle suddenly changes. There is a fast food. There is a lack of physical activity. And so probably that is in India also, middle class is having that those type of trends. So we have a very large country, but still we have got a large number of people who are lean, overweight rate is low, and age is also low. And the most interesting I find is Japan. Japan has got the highest age. Japan has the highest longevity even compared to the European countries, but the death rate is very low compared to, it's almost less than, it's 111, half of India also. Because Japan, if you see in spite of the high age, the obesity rate or overweight is just 27%, almost 1/3 of the Western countries. So obesity is coming up as a big, epidemic from the epidemiological perspective, immunity to COVID. The obesity is the biggest marker. I wouldn't say direct, it is a marker because, as I said, obesity may be associated with other diabetes or hypertension. And also obesity, your lung function is affected. So the pulmonary function is directly affected by obesity. And of course, there may be other, as I said, as an epidemiologist, we can just show the pattern. It is for the basic scientists to see how obesity is affecting the immunity. And then some studies, other things also, which we have seen, immunity, there are other overall health, positive health is related to good immunity. I mean, at an epidemiological level, we say that. So we had done some studies. I have given the references a few years back. That was almost 5 years back. We did a study among the vitamin D levels, because nowadays the lifestyle is changing. People are young boys, in our times, young girls, we used to play outdoors whole day, but now people are mostly indoors, the younger generation indoors. So we did a study where we found among the students and among the faculty, we found the students were 4 times more likely to be deficient in vitamin D compared to the faculty. So the younger generation, we have published the study, and the younger generation were 4 times more likely to be deficient in vitamin D. So vitamin D is also directly or indirectly related to immunity. Then we did a study upon diabetes among a rural and urban field practice area. So we found a very high rate of diabetes, almost 9 to 10% people were diabetics. And in the rural areas also we are found, and that study also we have published. So what was alarming was that people, the young diabetics, the 35 to 40 years age group, as I said, the Asians are more likely to get this non-communicable disease decades earlier. 50% of the young diabetics in 35 to 40 years of age were not aware of the diabetic status, only detected during the survey. So this is another very important that many times we hear the young people dying without, most of the time they will not be aware of the comorbidities. It is not recorded. So, and now in the second wave, we had large number of cases of fungal infections, mucormycosis and all that, diabetes. So these, when we want to cope up with this, we have to take care of the overall health. In future pandemics also, in the rural areas, in the primary health centers, the metformin or primary drugs for diabetes are also not available. So, and all studies have found a similar level of non-communicable disease in rural areas. So most are unaware. And then we did a risk factor study and we found that central obesity and all are also catching up in the rural areas. So this time the cases for fatalities are also high in the rural India also. So these are the actual ground on which the COVID. So we have to take care of these other factors to increase the immunity against earlier I used to teach that this lifestyle and physical activity and diet is important for non-communicable disease. But after the COVID experience, after this pandemic, we have to change our teaching to younger generation. We have to say that even for non-communicable, even for communicable disease, infectious disease, lifestyle, obesity and other things are perhaps more important, because communicable disease will kill you in a week, whereas non-communicable will kill you in 20 years. So perhaps these things are more important for acute communicable disease, where you are more susceptible because of these other comorbidities. So these are, as I said, these are the changes. In our time, we used to go to college in bicycles. Nowadays, people are going in cars. So these are, perhaps we were coming towards the generations, through the generations, this was an inevitable thing to happen. That in a cycle, you got a physical activity, you got open air, ventilation. Because as you know, these communicable disease, particularly respiratory infections, are in closed spaces. So now everybody is huddled in a car. There is no ventilation. Then go to an office or school or college, everything is closed. There is no open air. And then they are not getting the vitamin D. So everything is adding up to it. Similarly, the office spaces used to be very long verandas and all, which are good ventilated. People were, now everything is in cubicles. So there is stagnation of air. So they are talking, and then they do lockdown, they put people inside such houses and offices. So it may, instead of outdoors and sunshine and all, where the transmission will be less, you can't walk out. So these are some of the wrong way the present pandemic has been tackled, which is not really based on science and evidence. So these are the office, small spaces and workplace now. So the architecture, the social changes, the architecture, all have contributed to it. Healthy meal. I have just taken the Japanese meal because, of course, I don't understand most of the year, but it looks very healthy because it has got vegetables, fruits, and that type of thing. So Japanese I have taken because Japan had the lowest rate of fatality in spite of a high age. So, but Indian diets, if you see Indian, traditional Indian diets are also very healthy, which are, but now gradually we are changing towards this diet, or urban Indians or even rural areas who are getting access to this McDonald's. Then the Sachin Tendulkar will promote the Coca-Cola and Pepsi and other things, the sugar, high sugar content in the soft drinks. So these are all, it reduces your immunity whatever way, as I said. But these are the trends. It promotes obesity very fast, and coupled with sedentary lifestyle. And I think in the lockdown also people have put on weight. This is from an American paper I have taken. They have done studies over the past 1 year, because repeated lockdown, many people have gained. I have also gained a couple of kgs. So these are all things which will make you more susceptible to COVID and reduce your immunity. So these are old Indian, as I said, this is just anecdotal. This is from a newspaper item, 105-year-old and 95-year-old, his wife. Both came out, got admitted for COVID, and both survived COVID. So, and there are some hypotheses also that the younger generation, they have been exposed to tough life, outdoor, as I said, vitamin D, and even after being 100 years old, most of the very old in India survived the COVID. Maybe anecdotal, we don't have, but there was even a epidemiologist like Lakshmi Narayan also, he mentioned that. Or probably another one hypothesis is that they have been exposed to so many coronavirus in their lifetime, related coronaviruses, because we used to mix, we used to get congested living conditions. So they say the cross immunity with other, it gives the infection with other coronaviruses like common cold virus, which are related to the coronavirus. It gives some cross immunity. So that may be one factor. It may be, I mean, there are multiple factors for immunity. So this is in the first wave, the slums, the most congested areas, it got stabilized. And in the second wave, and they developed the immunity due to natural infection. Because now there is lot of debate that after natural infection also whether you take vaccine or not. But as per the scientific principles of immunology or principles of epidemiology, natural infection gives more robust immunity than perhaps vaccine immunity, which we don't know how long it will last. We have done studies in our field practice area, not only field practice area, we did a study in the whole municipal corporation of Pimpri-Chinchwad, a population of 27 lakhs. We were given the task of controlling COVID there, and we were given the task of carrying out a zero survey last year after the first wave came down. September, the first wave came down. October, we did a zero survey, 5,000 population. We did antibodies. 35% we found positive. And this 35% was not homogeneously distributed. The slums in that corporation and the tenements, some of the slums and tenements had almost 80% people showing antibodies, 70%, 60%, 70%, 80%. And on the other hand, the housing societies, the middle class and affluent people, there the percentage of IG antibodies was just 10 to 15% or 20%. So there was uneven distribution, and this is what happened. The people at the lower socioeconomic strata, they developed immunity first in the first wave. And the people in the higher strata, they did the social distancing, lockdown, they could afford to work from home. So they could keep themselves, but on the other hand, they were left vulnerable. So that is how the second wave, there was a sudden rise, because it gave a false impression that the people in the lower socioeconomic, they had developed some immunity or herd immunity, whatever you call it. And the upper class, 70% or middle to upper class, they were susceptible. So they had no immunity to, and they were, once the first wave receded, it almost came down to base level. The whole country was misled, thinking that the pandemic is over, and suddenly everything opened, and we know in the second wave suddenly rise. So anyway, probably now ICMR is also planning to do after the second wave receding, we are going for another zero survey countrywide. So we will come to know the exact picture. So this is the second wave, 80% or 70% were left vulnerable. Now, another concern is that what about the immunity in children? That there are a lot of speculations that the third wave will affect the children because the adult will get vaccinated and all that. They are planning the ICU for children. But fortunately, the immunity against infectious disease are very high in children, because they have a very big thymus gland, and this thymus gland produces the T cells. And you know, in COVID, more than the antibody, it is the T cell and memory cells which here. So children are very robustly protected. So the third wave will not affect the children. And there are some data also to support this proposition, because what does there is a apprehension that in the second wave more children were affected. This is the of the clinicians, but it is not because more children were percentage wise children were same. It is that overall the cases were 4 times more. So all age groups were affected. So more children got affected. It gave a wrong impression that younger age, because we have got more children and more younger population in our demography, because we have got an older population much less, and so because of the sheer numbers we had, but the percentage was just 2 to 5% in both the waves. Then they have studies. I have given the reference from 7 countries in Europe. At the peak of the first wave, they did studies on the impact of COVID on children. So they have found in the 3 months of the observation, out of 42,846 confirmed cases in children who were admitted. There were only 44 deaths, and which gives a infection fatality, which gives a case fatality rate of 0.1%. And if you see for every confirmed case, there are 20 to 30 asymptomatic cases. If you include that also, the infection fatality rate comes down to 0.0005 in children. And they compare it with the deaths in children from other causes, the non-COVID say. So they found 13,200 deaths from other causes. Only 44 deaths from COVID at the peak of the pandemic. And accidents was the highest cause of death in children. That is 1,056 child died of accident. Other respiratory infections 308, and influenza was 107. And COVID deaths in children were only 0.33% of death from other causes. So even at the height of pandemic, 99.67% of deaths in children were due to other causes. But the amount of publicity and panic and the phobia is so much by media and other experts that we have closed the schools, the parents are afraid, and children are also going into this restlessness. So then they have, Sweden is the only country which kept the schools open throughout the pandemic. So we have got from data from Sweden also, only one child in 1.3 lakh required ICU admission, and only total 15 children were admitted to hospital due to the study periods. In the ICU, only 15 children were admitted in ICU. 7 of them had multi-inflammatory syndrome, that is the Kawasaki syndrome, which gives a lot of fear because the name is also very big. So only 7 had that, and all the 7 recovered. And out of the 7 who went for Kawasaki, 4 of the children had comorbidities. So none of the children died. And mean time in ICU was 4 days. You see, children can also have comorbidities. You know, particularly in our country, 2,000 children die every day. Nobody gives any publicity to that. Every day, year after year, every year 8 lakh children die due to preventable causes. Because it is a disease of poverty, nobody gives here. So, but COVID, we are worried that if we won't open schools, children will die. It is nothing like that. Children will die, I am concerned. They will die of malnutrition. They will die of the collateral damage of loss of livelihood. They will die of poverty. They will die of other infections. Or perhaps including COVID also, because the immunity will go down. So other concern is, okay, children are safe, but they will spread it to other adult members. So they have got studies, they have published studies that children do not transmit. So they have found majority of the children got the infection from adult, not the other way around. Children hardly infect adults because their height is less, so they can't cough into the face of the adults, it is go down. Secondly, most of the children are asymptomatic, so though whatever people may say, asymptomatic also spread, but asymptomatic spread very, very less. And then another concern is that they will cause community transmission. So there is again, which is more common in influenza. The studies have done, the influenza is more transmissible in children, and the influenza mortality is also more in children. But when we had the last pandemic, 2009 H1N1, mostly the casualties were in the young age group, including children. That time we did not close schools, but it is strange why we have left the school closed this time. Immunity after, as we have already discussed, immunity after should influence vaccination policy, because immunity, we are talking of immunity whether from vaccine or from natural infection. So we should combine this rather than going for mass vaccination, because after the first wave, as per the ICMR third round of sero survey, 21% of the population were infected, had IgG antibodies after the first wave. And the second wave was 4 times larger. So if you just do normal arithmetic, so 20%, 4 times more will be almost 80%. So let us say 60% or 70%. So let us say 50% of people get IgG antibodies from natural infection. You will say 50%. Now everybody knows there is such a big crisis of vaccine in India. So you will save 50% of vaccination, and everything is linked up. RT-PCR is linked up, antibody test linked up with your Aadhaar card. So you can have a list of people who have already got the infection, natural infection, IgG antibodies, and you can exclude them at least from the first round. You can save a lot of vaccines, and you can reach herd immunity faster by vaccinating those people who have not been infected. And even though they say after natural infection, we have, as I said, last year we identified 1,500 people in the Pimpri Corporation, where did the Sero survey. We have got the list of those people, and this time we are following them. After 8 months, we are following them up to see how many of the 1,500 who had IgG antibodies, how many of the 1,500 have got reinfection. Up till now, this month only we started following them up. We have contacted 500 of them. Out of 500, only 4 of them had a reinfection, which was very mild, which did not require hospitalization. So at least for 8 months, and they were staying mostly in these crowded areas, slums and tenements. So this is immunity is there, at least 8 months it is there. And as I said, it is not only antibodies. They say antibody is not the immunity. It is the T cells. It is the memory cells which can be activated at short notice. So and now the recent article in Nature also has come that natural immunity is long term. So the way forward should be high risk population to be vaccinated priority, and it is not possible to vaccinate all. Care of known COVID cases will not be interrupted, and research is required. Even for child also may not require vaccine at this stage. Natural infection protects, and even in our Sero survey last year, we did 12 to 18 years were also included in the Sero survey last year. There was no less antibodies in them. The Sero survey, there were 35% were positive overall. Children were also 34% positive. So it is not that they are also not exposed. They have been sheltered by closing schools and other things, and they require vaccination and all. Because, crowded living conditions, children, adults, they are equally exposed. So if the adults develop natural immunity, the children have also developed natural immunity. So only those who are high risk, morbid, I may say even younger age group with comorbidities, you may immunize. I'm not saying you don't immunize, but you should be selective. It will save vaccine. Increase in health budget, overall health services have to be good. It is not only in one isolation, one disease at a time. As I said, most of the comorbidities have caused more deaths, like diabetes, like hypertension. We are totally in the rural areas. There are no facilities for treatment of non-communicable diseases. And control obesity, because urban India is becoming obese like Americans or Europeans. So promote healthy food habits, lifestyle, avoid sugar and soft drinks, avoid fast foods, encourage physical activity by creating environment, cycle tracks, playground, and swimming pools. All are closed during lockdown. So there is a conclusion that there is a old saying by Sun Tzu. Ironically, he is an old Chinese philosopher general, and we are dealing with a Chinese virus. He says, if you know the enemy and know yourself, you need not fear the results of 100 battles. We know the enemy, it's a virus, and it has a mortality rate of just 0.3%. And we know that is the virus. And we know ourselves also that if we are obese, if we have comorbidity, we are vulnerable. So we know the virus, enemy, we know ourselves. We can, even if we have comorbidity, we get treatment for diabetes, we get treatment for hypertension. We can face the virus and we will win the battle. If you know neither the enemy nor yourself, you will succumb in every battle. And again, the father of medicine, Hippocrates, and I am sure that our Susutra and our Charak also must have said the same thing, that most important, the last sentence, that wherever you go, you see the seasons. It has got a seasonal, say winter may more, and health implications of the winds, the ventilation. We should have good ventilation. Then whether its inhabitants are given to excess passivity of physical labor, and all this affects the health. So it is still true after, say, 2000 years. Whatever Hippocrates said, whatever Sun Tzu said, it is still true, and in the time of this pandemic also. So these are the references we have got, on which I have been talking. So these are some of the references. I think that's all. Thank you.
Thank you, sir. There are a few questions.
Yeah.
Is there a possibility that in Western countries or high income class reporting was prompt compared to low middle income countries?
Reporting, there have been, if you see, Asian countries also, there are some countries like Japan, which are as good as developed countries. So if you see that way consistently, if you see, okay, reporting may be 3 times less, but their mortality is 10 times more. So even if you account for that, and even if you account for that, I mean, it is something which shows that we lack confidence in ourselves. And in fact, there are other way around also. If you see, they have been over-reporting in Western countries. People RT-PCR positive and he dies of a traffic accident, it has been labeled as COVID death. Because there is a lot of vested interest were there, because the American model is the corporate hospital model. Similarly with Italy also, they have got very poor public health services in spite of them being very rich. So the corporate hospital were getting extra incentive to treat COVID patients. They got extra incentive for ventilators. So they were labeling all cases as COVID. And in fact, in between the WHO or CDC, I think CDC had given a report, then they withdrew it, that actual COVID deaths were only 96, only 4% or only 6%. That came last year when the peak of, because actual COVID means either people dying due to COVID or dying with COVID. You see, most of the people there who died above 80 years, above 60 years in the nursing home, they had number of comorbidities, terminal illness, and you have a RT-PCR, and it goes both ways. So you see different countries, even, and India is testing more than 20 lakhs a day. The testing rate is also good. And death you cannot. That's why I have compared only death. I did not compare cases. So death you cannot hide. I mean, it may be 2 times less, 3 times less, but Western countries rates are 10 times, 20 times more. Death rate.
Is there any seasonal factor on COVID-19 rate?
Yes, seasonal factor is definitely there. In the Western countries, it comes every autumn, winter. It is all respiratory disease, whether it is influenza, now it is COVID. And our country also, in the spring, the respiratory infections increase. You have measles outbreak, you have chicken in the month of February, March, because of the dry epithelium or something respiratory. And of course, post rains and winters. So the seasonal pattern is there.
Since the children are not yet being vaccinated, so how can we protect them in our next third wave? And how do we
the children will protect themselves. The nature will protect them. As I said, they have got a very thymus here. And I am very happy that if you read the latest statement by the Indian Association of Pediatricians. So Indian Association of Pediatricians have said that children will not be, there is no evidence. Everybody is cautious nowadays. So they said there is no evidence to suggest that children will be affected. That is the strongest they have come to say children will not be affected. And yesterday only there is a publication in Lancet by a task force of Indian doctors, Indian researchers, which have published an article that the third wave will not affect children. I mean, or they may be saying there is no evidence because nobody wants to commit something. So be assured, children will, as I said, the serosurvey shows that children are already infected. At least our serosurvey showed last year. We did that. We found in the pediatric age group also 35% serosurvey. So what is happening? Everything is happening simultaneously. So now we will come to know after the 4th serosurvey. Hopefully it will take place fast. After the 4th serosurvey, we will know, and we should not be worried about children. Children have got very strong immunity.
Thank you, sir. You provided us with concise epidemiological data, and we could actually relate to you because we as naturopaths also believe as obesity is one of the, like you can say, mother of all diseases.
Yeah.
So, and you as well said that obesity is the marker of COVID. So we could relate that returning back to nature, a ventilation or vitamin D or sunlight can help us to improve immunity. So we are really thankful for your very informative session and for your invaluable time. Thank you, sir.
Thank you, madam. It was an honor and a privilege. Thank you.
Thank you. So amongst us, we have our next speaker. Again, we are moving to our last speaker of today's technical session. He's a distinguished personality in the field of naturopathy and yoga. Post his BNYS from JSS College, he worked with many prestigious institutes and hospitals. NI in Pune, Netaji Nature Cure Hospital, Ernakulam. He's internationally qualified NLP practitioner and holds his expertise in style medicine, lifestyle medicine, and healing through mind hacking. Currently, he's working as Chief Medical Officer at Prakriti Shakti Clinic of Natural Medicine by CGH Earth and serving as National Executive Committee member Enigma. Member Committee for International Yoga Day Celebrations 2021 Government of Kerala, and still more in the list. So today he will be enlightening us on establishing and running a naturopathy setting with